major mood episode, including the direction of the polarity, the symptoms of formation in overacute mood episode. They also significantly affect the long-term cause and the outcome, including suicidality and a form of self-destructive behavior, such as substance abuse, eating disorder, and so on. What treatment? Already we talked about, since yesterday, the combination therapy, of course. I not only, also Marta told before that the antidepressant alone have the risk to induce the worst of the depression of the older people. I underline, never use antidepressant alone. Never use antidepressant and benzodiazepine together. But in order to avoid the increase of the instability and the development in patient of the dysphoric mixed states, a correct maintenance therapy, however assessed and chosen from case to case, based on the clinical picture, should always include at least 1, 2, or 3 mood stabilizers, together with low doses of antidepressant, above all in maintenance therapy. The difficulty for the psychiatrist or the clinician to do a correct diagnosis, because the mixed states are very confused in their behavior. They prescribe antidepressant alone or together with benzodiazepine, with very frequent, and don't put emphasis on increasing the dysphoria following this inadequate treatment. For this reason, the presence of a new rating scale, and go to the focus of my lecture this evening, mainly focused on mixed state syndrome is crucial. What modality has the clinician to do a correct diagnosis? I thought to give my contribute, hopeful every of you, any other clinician might confirm or not the useful of my proposal of this rating scale. You can see also in the book that Psychiatria Tavormina published. Because we have not. Marta, I know, is a great expert of a rating scale, and I would like to know after your opinion, really. There are no specific rating scale for mixed states, so that I thought to describe it and write, but this is a self-administered rating scale. I don't use usually in my practice because this rating scale is inside my mind since several years. Anyway, it's important not work only my mind, but if I think this is an important way to diffuse, I wrote, I described in the scheme as been published. Hopefully you can use it, and next year we shall see the results. I read summarizing, but you can find in the book. It's important to remark, as there have been a period of time during the last 3 months when you frequently were or present or felt hyperactivity, quickly alternating with periods of psychomotor retardation or apathy? Yes or not? Some of these items also and sub-item explained after in this min. If yes, how many days a week? Second, the person moved together with irritability and or internal tensions? Yes, not. If yes, how many? For how many days a week? Substance abuse, substance abuse, alcohol and or drugs? If yes, for how many days a week? Disorder of appetite similar. A sense of despair, anhedonia, delusion, hyperactivity, sexual activity, for how many days a week? Insomnia, for how many days a week? Reduced ability to concentrate in mental activity, for how many days a week? somatization of course. Additional point at the end of the rating scale, I put 3 items to focus the temperaments, as I talked before. The first, the hyperthymic, the second, the cyclothymic temperament, the third, the depressive, anxious-depressive temperament. Mixed state diagnosis of at least 2 years are present. Double score for the points with the sub-items, and with this final score, medium light level of mixed state from 2 to 6 score, medium level of mixed state from 7 to 12, high level mixed state from 13 to 19 score. Obviously, the positive result of this rating scale, I wrote my symbol of my name, GTMRSS, will enable to do a correct diagnosis inside the group of mixed states, the subgroup I put it from a physical scheme, or the subgroup written in orange over my scheme. But the clinician will need to do a correct diagnosis, so that the clinician will need a special care to do a correct diagnosis of the sub-diagnosis of the subgroups. It's important to weigh in the correct way, to begin, sorry, the correct way. In conclusion, the consequences of a lack of recognition and treatment of a mood disorder mixed state can be higher risk of suicide, reduction in the expectation and quality of life, increasing the loss of working days, increasing use of health care resources, including for recurrent disease. And finally, the mood can become chronic, and clinical picture can worsen progressively. I hope this rating scale will help clinicians, psychiatrists, and other doctors, GP, for example, is easy to use. And I like very often to conclude with this important sentence of Professor Akiskel. He presented this slide here in 2009, where you were present, maybe you remember, that because it's important to use the mood regulator, but also the clinician, long-term caring the patient is a really interpersonal mood regulator. Several of these topics we included in this important book, The Management of Bipolar Spectrum Disorder, management by Mark Agius and myself. And for population, we published 1 year ago this guide for population in both English and Italian language. And I say bye for the next edition, leaving for you this charming picture of the Iseo Lake. Hopefully you appreciated this place, this food, this countryside, and this picture. Thanks very much.